We each have an hour to speak, right? We're here till midnight. No, thank you all for the invitation to speak today, and try to be brief with some introductory comments. We'd love to hear from you. There's a lot of folks in the audience that have already thoughtful about this stuff. So we heard great presentations this morning, sort of framing the issue of the shortage of physicians in general, especially in these shortage areas, and secondly, the shortage of Latinos in both specialty and primary care. So the challenge for us, I'm at White Memorial Medical Center, and I'm the co-director of the Family Medicine Residency program, as well as the medical director for our faculty practice. And so the challenges of recruiting the workforce is really critical for us, especially because we serve a population 90% Latino. Almost all of them are low income, about half of them are Medi-Cal eligible, and then there's another sizable population that is covered California eligible, and as we were talking about, they're $1 too rich for Medi-Cal, but they're still poor. So it presents a lot of challenges, and of course the cultural services that they need are really critical. And so our role in education of residents has been to recruit folks from the community. You know, the whole concept of growing your own. Mariela Garcia, who's here, was one of our peer mentors for our high school pipeline program. Where we've had 6 of our former students come and train with us, and 11 that went into other fields of medicine. So, you know, that part is a kind of a fun part of it, and like Dr. Magaña presented this morning, the biggest success is that we were able to get kids who normally would have dropped out of high school to not only graduate from high school, but actually get to college and be able to graduate. So that part of it has been a part of the mission of the residency program. The key thing was really recruiting at the high school, excuse me, at the college and medical school level, because those are the kids that have already cleared certain barriers, and they're able then to benefit from enrichment programs that we provide for them. So part of this mitigating the shortage of Latino physicians definitely is a pipeline program. And those of you who know, as our philosophy in our pipeline K-12 is that the recruitment of the future doctor starts at the first prenatal visit, because that little fetus that is developing needs to be nurtured, and it's about educating the mom and the dad, even if they're not married, about their responsibility towards the development of that child, and even towards their own education. So building a culture of achievement for us has been part of what we do as family physicians. But that'll only get us to a certain point. I think the second thing is to really look at every job that we offer in our practice as the beginning of a pipeline for adults to have meaningful employment and gainful employment. So what we decided to do is we located our 4 faculty practices specifically in health profession shortage areas. That was part of our mission. And we committed that we would recruit every entry-level job from the community and be able to train them so that they would get the skills, and even if they left us, that we knew that we had embarked them on their own upward mobility. And so that's the economic engine component of the medical practice. The third part of that was we provide a scholarship program for those entry-level jobs for their own career development, as well as for their children. Because we wanted to start saying we practice what we preach. It starts at home, promoting, again, higher education amongst the ranks of our trainees and employees. The second thing was looking at the recruitment of the college students. As you know, when you're a college student, you're that pluripotential stem cell. You know, you still haven't decided what you're going to be. So we want to nurture the careers of those college students to the extent that they're interested in health. We point them in the right direction. So a couple of our nurses are part of that pipeline program, as well as several of our physicians. And then, of course, medical school and the residency program become part of that. So every job is a chance to create a pipeline, and every pipeline is a chance to create a job for the community. The other part that we believe very seriously is this whole idea of breaking the barriers to scope of practice. And there we differ with CMA and our colleagues in the mainstream of the medical profession. And it starts with a basic principle. We're family physicians, so we intrude on everybody's turf, right? So when we demand to be given the opportunity to practice our field, why should we then presume to limit the opportunity for others to practice? There are some important nuances, and these are discussions I've had with Senator Hernandez, who's been a champion of doing away with the scope of practice limitations. And that is that, just like us, when we finish medical school, we're not ready to practice. We need to make sure that a nurse practitioner or a PA or an optometrist also have that seasoning to be able to be helpful to their patients and not harmful to their patients. So they need time. They need either a formal residency or on-the-job training that allows them to get that seasoning. And the other thing that I've looked at is states. There are 17 states that allow nurse practitioners to practice independently. And what we found is that it has unintended consequences. Because in those states, when nurse practitioners were allowed to practice on their own, all they did is they left the practice they were already working with. So we added 0 FTEs to access. And we simply created a new practice that has its own overhead that actually raised the cost of healthcare. And we found that nurse practitioners are not different than physicians. They tend to want to subspecialize. So a lot of the nurse practitioners who were in primary care actually went on to become oncology nurse practitioners, cardiology nurse practitioners, ortho nurse practitioners. They got paid better, no fault of theirs. But it also tended to drive the cost of healthcare up, and now it actually had an adverse effect on the primary care FTEs. So we have to be reasoned and thoughtful about this, and I think we can get to that point. So we believe very much in team-based care. That's another way to mitigate the shortage. All of us working to the highest level of our license, or we have paraprofessionals like community health workers and pharmacotherapists, that they be allowed to work to the highest level of their training with the right supervision, of course, so they're not practicing medicine inadvertently. But the idea is really to delegate those resources. I was looking at a study by the California Healthcare Foundation. Thank you, Dr. Hernandez. They do a lot of phenomenal work. It's your one-stop shopping for any policy issue you want to study. And one of the studies they found is that among physicians, we spend about 40% of our time doing administrative work, clerical work, that someone else can do. In a team-based setting, we can train our MAs to do some of the clerical things of, populating our evidence-based guidelines for the management of patients with chronic disease, for example. Always looking for ways to do it better, faster, cheaper, and release the clinicians to do what they do best, which is actually take care of patients. The other thing is using the new technologies in healthcare, mobile technologies. A recent report that came out from Hewlett-Packard shows that among low-income populations in California, 80% have access to a cell phone. We always talk about the digital divide, but it's actually narrowing. Now, it's not a smartphone, so they don't have access to the internet necessarily, but they certainly have access to secure texting and other messaging that we can use for patient engagement, but to stay connected with them. So we have to use that new technology to improve that. Kaiser just released a report that out of the 110 million visits they had last year, 52% were now delivered through mobile technology or some other kind of telecommunications, not face-to-face visits. So now we have to look at payment innovation as a reward for doing those things. And that's a challenge I'm sure we'll hear from Carmela about the community clinics, where HRSA and others are still stuck on that face-to-face visit, and how do you allow the clinics to diversify around the new technologies. But I think we really need to take advantage of that. And lastly is that besides reorganizing healthcare, it's really learning to be better partners with people that we have been siloed away from in the past. So for us, it's this new movement on the marketplace and the movement on ACA to pay for value, to actually reduce unnecessary ER use, unnecessary hospitalizations, and actually penalize the hospitals for doing that, now has motivated them to participate more with us, to be more proactive, more towards prevention, allow that team-based care to manage populations more effectively, and to actually partner with the safety net. So the community clinics are a strong partner for us. And in fact, we just submitted our application, as I mentioned, to Carmela to turn our primary care clinic into a federally qualified health center and be more of a partner to the safety net. We're also working with a whole person care project with the county. We call it Share the Care. Those patients who are very ill, mentally ill, with substance abuse problems many times, bounce around from one facility to another. So we're all going to see those patients. We see them under catastrophic conditions. So much better if we can actually proactively manage their health, manage their social needs, and actually be able to say that every admission is a planned admission, not a catastrophic admission, and everybody wins, starting with the patient. So those are my introductory comments, and I would look forward to learning from our panel as well. Thank you.
Is this going to work? Hello? Sure. Is it working? Can you hear me all right?
Testing, test, there we go. All right.
Good morning, everyone.
Good afternoon.
I have a question for you all. How many in the room are students? How many are residents? How many are physicians? How many are Kaiser physicians? And how many of you work at a community health center? Okay, great. Got a couple of community health centers in the house. Wonderful.
good to see
all of you here, and really commend the students as you're embarking on a very important journey that will help address this crisis we're in, which is the lack of Latino physicians. And I guess I'll switch over to the other mic. Sorry about that. Okay. Well, as you can see in my bio, I have been involved in this effort for 25 years now. And I started as the founder of the Latino Coalition for a Healthy California. And when I think back, I know Hector's, but he was with me way back then too. And the situation for Latino physicians was pretty much the same situation. We were about the same percentage of the physician population 25 years ago, which means that there's been pretty dismal progress in the past 2 decades, which means absolutely not enough has been done to address this issue. But yet, because we've made such huge progress on another front, which was where I started 25 years ago as well, which was healthcare reform, when President Clinton introduced a healthcare reform proposal and there was no Latino voice in healthcare for the state of California, which was why I created the Latino Coalition for Healthy California. Flash forward 25 years and we are in the midst of implementing the wildly successful in our state Affordable Care Act, which from a Latino point of view has really been tremendous because Latinos have been the largest beneficiary of the Affordable Care Act in terms of having access to coverage. So that's been tremendous. So tremendous progress on the access front, dismal and pretty much no progress on the Latino physician front. So from my perspective, as someone who's been involved in this for so many years, I really do see the issue of creating a diverse workforce for the state of California as the next frontier of where we need to go in looking at healthcare issues for the state of California. And really, it's not just an issue in our state. The whole workforce shortage, a primary care workforce shortage, physician shortage, clinician shortage is an issue throughout the country because my colleagues in community health centers are facing this issue throughout the country. And just for those of you who aren't as familiar with community health centers, I know it's been mentioned that there's 1,200 sites throughout the state. One thing I will add about that is they are serving close to 6 million patients. So I know there's been a lot to talk about Kaiser, and I know Kaiser serves a lot of Latinos. Well, community health centers are serving over 3 million Latinos in the state of California. And largely under 200% of the federal poverty level, many under 100% of the federal poverty level, and certainly a diverse set of Latinos too, with many of the immigrant community as well as residents and citizens being served in community health centers. So when we are concerned about a Latino physician workforce shortage, I can tell you that community health centers have a tremendous concern about this as we are striving to serve a very ethnically diverse population, but principally Latino. It's also an issue for us because community health centers were founded on a principle of being culturally and linguistically competent and having a workforce from the community and having the ability to serve the community. So with such a lack of diversity in our clinician workforce, and not just physicians, across the board, the absence of adequate numbers of Latinos in the workforce is a major, major issue for the constituency that I represent. So what I want to share with you today, and just thinking through how do we address this issue, I want to share with you a recent victory that we've had in the state legislature, because I really think it lays the groundwork for how we need to think about addressing the Latino physician shortage. And some of the principles that we've learned from this initiative that the California Primary Care Association undertook this last year, I think are good lessons for how we go forward addressing the Latino physician issue. And in looking at the whole workforce issue, our organization decided that we were going to emphasize and work on the issue of the physician shortage initially. So that is actually the issue of medical education and the lack of adequate residencies in the state of California for primary care. And we decided to tackle the issue because in looking at workforce, what we felt we needed to do is that we were going to need to, number one, be bold. We needed to wake everybody up that workforce is a priority issue. We needed to be proactive and come up with an initiative that we could just go forward and introduce. And thirdly, realize that we were going to need to do it in partnership. That the community health centers were not going to be able to do it alone. The workforce issue is an issue that was affecting others, the entire industry. And so this was something that we knew that we could find partners in, and that was going to be our approach. So another thing I will mention about why we took on the issue of residency, I know there was a lot of talk about the Kaiser Medical School. I commend that effort. I think it's going to be awesome. But let's not forget another major victory that's actually could revolutionize residencies. And that is the Teaching Health Center concept. And this was something that came out in the Affordable Care Act that actually allowed for the creation and funding of residency programs within community health centers, and allowed community health centers to have accredited residency programs. So this was an opportunity that didn't exist for us previously. And as a result, there are 6 teaching health centers in California and 60 throughout the country. That is really creating a whole, I would say, quiet revolution in residency practice, which historically is focused and been hospital-based, and you all know it. Well, community health center-based is what teaching health centers are about. And so I think this is an effort that we thought there was an opportunity to build on in the state legislature, because it's been a federal effort, and try to get our state legislature to embrace the Teaching Health Center program, basically leveraging federal dollars. Because if you always have an opportunity to promote something as leveraging other funding, that's always more attractive. So what we decided to do was join forces with the California Medical Association and the family practice physicians, which were looking at expansion of the Song-Brown program, family practice residency programs for the state of California, and to add the Teaching Health Center concept to it. And to go forward with a package asking for a $100 million investment in primary care residency in the state of California. And when I say talk about being bold, that's pretty bold. And the reason why is because we have a governor who really has just not been committed to bold initiatives in healthcare. There hasn't been a significant additional state investment in this program for a long time. It's been cut back, if anything. And it was really just putting our stake in the ground and saying, this is a really important issue, workforce, and the state needs to invest in it. So lo and behold, this coalition effort, which was even much broader than the 3 organizations I mentioned, Planned Parenthood, a whole range of provider types of organizations really coalesced around this initiative, and ultimately we were successful at securing the $100 million in the state legislature, which will be about $30 million a year over the next 3 years investment in the expansion of current Song-Brown and Teaching Health Center programs, as well as the creation of new ones, which is really an important opportunity. And there's also a $1 million investment in state loan repayment, because certainly loan repayment is another very important piece of this puzzle, which we should also touch upon. So that was really where we're kind of at this point now, with the community health centers having achieved this along with the Medical Association. It's really elevated now the workforce issue in the eyes of the legislature. And that was our original goal. When I sat down with my staff and said, we need to be bold with legislation, I really didn't think it was going to be $100 million. I was going to be happy with maybe if we had 10 to 12 million for teaching health centers. That would have been incredible. So it's kind of an example of, never say never. And another piece that I think the Latino physicians have built on, is we also published a report to kick this thing off. We had a report about Horizon 2030, where we documented the lack of adequate physicians in California, where we predicted that we were going to need over 8,000 physicians, new physicians, by the year 2030, which is 30% more than we currently have. To meet the need, and we started with that report to begin to educate the legislature, and then on top of it we put through our ask for $100 million to address it. So it started with putting out evidence, putting the issue out there, saying it needed to be addressed, and then coming through with a proposal in order to have a solution, which is really key. It's one thing to have the report, but you got to follow right along with the proposed solution to build on the momentum of your report. And that was always part of our strategy. Do the report and then do the proposal and try to push to get it through. And so ultimately where we stand now is we have a lot of work to do. Of course, once you get a policy passed, key is implementing it. The Song-Brown Commission just met earlier this week, and we have our work cut out for us to ensure that these dollars happen and are allocated in a manner that we feel is going to be beneficial to our constituency. So the advocacy doesn't end when you get the legislation or the budget item through. Then in some ways the real work begins to ensure that implementation is correct. So you've got to be in it for the long haul. When you take on these kind of initiatives, again, it's just not enough to get the bill through. You have to then continue your advocacy efforts with the regulatory body or the administrative body that is involved in implementing your initiative. So for our association, that's a huge priority right now. Another thing that we continue to do to try to keep visibility on this issue is continue the efforts to study it. So we have one report that I mentioned, and now we're working actually in partnership with Kaiser Community Benefits and the California Healthcare Foundation at a primary care workforce study where we're going to really document the shortage, not just for community health centers, because remember, we're working in partnership, we're going big, it can't just be about us. So we're going to be looking at the primary care workforce shortage statewide overall, how it's affecting all sectors with recommendations and documentation of what is needed. Again, you need that data so you can go into the legislature and actually show and demonstrate the shortage. And again, I think LPOC has done that with the recent study that they have come out with. So we're going to be doing our own study, which should be coming out in the new year, which will help support another set of initiatives that we can bring forward. And then the next step that we want to do as an association as well is build on the success of this coalition effort with the Medical Association, the family physicians, and others. Because it's very clear to us that it was by joining forces that we were successful. The CMA is a very powerful lobbying body. The community health centers have our own cachet with the legislatures as well. And it was actually a very good partnership because the legislature sees the mainstream medical profession and all that they bring to the table, but the community health centers, when it comes to serving the low-income Latino population, the diverse population, the Medi-Cal population, that is a whole other piece of the pie that CPCA brings to the table, and so together it was very powerful. And so we want to continue to build on that particular coalition, and so what we intend to do is hold a series of, I guess, convenings, if you will, again with the focus on Sacramento public policy issues in workforce. So looking at things like loan repayment, looking at things like residency programs, looking at things like pipeline programs, and thinking through what are the public policy solutions that can be brought forward. And again, from CPCA's standpoint, we can't bring forward all these initiatives ourselves. It might be something, there might be a solution there that another group might want to take on and run with that we can support. And so really it's putting out a range of possible solutions on the table and then hopefully building a coalition around a number of them, a few of them, one of them. That's what we want to explore with others. So I absolutely think an issue like the diversity issue is prime for this discussion because we've woken up the legislature to the need to look at the workforce issue. People get it now that there's a workforce shortage. There's a mounting growing coalition in Sacramento that are parroting this important message. But now we need to really more strongly bring the diversity lens to it. And that is what hasn't happened yet. So in terms of future opportunities for the LPOC, I think this is where your organization comes in and is so important. You put it on the table by publishing the report. You're working with legislatures. You have the attention of people like Assemblyman Arambula, our Senator Hernandez, who's a big champion on workforce, Senator Pan, others who really care about this issue. So you've already you've planted that seed, you've lit the fire, you've put the data out there. And so now it's a matter of working with them more closely on what you think the best proposed solutions are. And then you've got to latch on to something. I mean, you might think there's 10 solutions. You just might have to narrow it down to that one that you can go forward with. And I'll tell you, that's what we had to do at CPCA. There are so many problems. Don't you think we need to address loan repayment? You know, don't you think we need to address not just physician residencies? What about NPs and others? I mean, we had to make an important decision, which was we're going to hone in on teaching health centers, we're going to hone in on primary care residency so we can make that splash, get the attention, get the ball rolling. So as far as we're concerned, the $100 million is a down payment on an investment in workforce. And it's going to need to be more, and there needs to be more funding to address the very issue that you are all in this room talking about. So I would say that you're very well positioned, and I would take the same approach that the California Primary Care Association took in doing so. You need to be bold, and I think you are, because I was at your session in Sacramento with the governor's office where you presented that initial report, and it was pretty bold, and Jose Arevalo, I commend you for that. I was very, very pleased and impressed. You need to be proactive, which I think you're being, because you're doing the research, you're getting it out there, you're putting it on the table, and then you need to find partners. Let's face it, you guys aren't a lobbying organization. You're a bunch of very committed, smart doctors. But that's tough without the lobbying arm. So you need to look at who has the lobbying arm. It's groups like the California Primary Care Association, the California Medical Association. There's a whole host of advocacy organizations in Sacramento, like the California Pan-Ethnic Health Network, who for 20-odd years have been advocating on the diversity issue, but haven't taken on this one. So maybe you need to approach them about taking on this one. So it's finding those partners, because you have a laudable cause, you have a worthy cause. I think you have a cause that a lot of people could get behind, but you're not going to be able to do it alone. So I encourage you to go forward. I think you've really taken the first very important steps. The California Primary Care Association stands ready to be a partner, and again, I commend you for your leadership, what you've done so far, and I'm hoping we can move forward together and really make some progress on this very critical issue. Thank you.
Hi, good afternoon. So I wanted to first of all just thank all the board and the new board member to LPOC, but I want to thank them for to having me on board, and I wanted to offer the perspective a little bit on this panel from a primary care physician perspective who really hasn't been in health policy. But over the last, it was something timely that came to me as a result of probably, I think, what Carmela was speaking about, because of my connection to the community health centers and my journey. I do have some slides, by the way, that I wanted to show with regard when I was speaking to my colleague about what I should speak about out here, and we were talking about how, well, you should, at least show sort of what Kaiser's ways and whatnot. And I am a Kaiser physician, but honestly, my heart started. I was born out of medicine when I went to training at a community health center. So I trained at the first accredited residency program in family medicine at a community health center in Massachusetts. Lawrence, Massachusetts, so it's near the border of New Hampshire, Greater Lawrence Family Health Center. So they are now 20 years old, but that I think not a day goes by that I don't think about my time there and the passion and the commitment that my mentors had to those populations, most of which were not Latino. And I think on the East Coast, outside of Boston, where I trained medical school, family medicine didn't exist. So there's few family medicine, programs. At that time, none. In Boston proper, we were 30 minutes from huge academic medical centers, but we're just a world away. And it's the far cry even now where I'm at. From the commitment, and that speaks to why I'm here as a primary care physician, the commitment and the passion, and why I think the shortage of physicians overall, supposedly 46 to 90,000 physician shortage in this country by 2025, by some predictions. But more than that, the shortage of physicians who are really committed to those communities. And that's where I trained. And it's difficult to find for a lot of reasons. I think that same kind of passion and vision, I think a lot of Latinos, especially that work in, in Kaiser or in any maybe system, it's, you're on a treadmill. So I think a lot of it's about the journey. And that's what I'm going to articulate what the leaders of Kaiser, diversity and inclusion, and I have a lot of respect for what they articulate as our vision. but it's the current vision, as it was just reorganized recently for Kaiser's diversity and inclusion, is equity and inclusion for all. And I think that this picture, this depiction really is a good representation of what that vision means. But in terms of getting to that vision, you know, it really is a journey, it's a battle, and it's an evolution, and that's kind of why I'm here as a primary care physician, because, you know, I in some ways we work in silos, and I had a good friend who actually happens to be MD and JD, now practicing law, not medicine, but who told me the analogy of medicine as being the sprint. Practicing medicine is the sprint. For those of you who are runners, I'm not a runner, I'm not an athlete, but and in law, maybe you can relate to this, is more of a marathon. And my husband's an attorney, so I see how, you know, when you're preparing for court and your cases and whatnot, perhaps, you know, as a physician, I'm not up at 2 in the morning, for, you know, writing papers and briefs and whatnot. We go through the day, and it is, I guess it is a sprint, and we work a lot in silos, so there's not that support. So that's one of the reasons I'm here, because I need to feel that team work sense that I felt like I had at the community health center, frankly, because of the sincere commitment of my partners to really be there, and most of them were you know, fluent in Spanish, and they were truly committed to those populations. And it's not something we see here. In fact, we're fighting within Kaiser to get even those doctors who are fluent in Spanish, perhaps non-Latino, to serve the populations, the Spanish-speaking population, because they don't want to, because it's too hard for them. And I have a hard time understanding that. So, you know, when I came out to California, back where I'm from the East Coast, you know, it was a big loss for me to not find that same model that I trained in here. And it didn't exist at that time. I don't think there were any family residency programs accredited in community health centers at that time, as far as I know. And there certainly wasn't the model that where I trained, a community health center model that had the kinds of impassioned physicians that were committed and were there for, you know, not just a year or 2 years, were there for the long haul, and are still there. And when I go back, a lot of them are actually still there. So things are different. Things were different, you know, in terms of the healthcare reform with managed care. We didn't have managed care back then, so things are different. But I think that, you know, it's a battle, and that's why I'm here. And I think of another analogy. I was thinking about sort of the struggle that I have as a primary care physician in terms of the shortage, thinking about the shortage and how we struggle in our own practices every day to serve our the populations, and to be kind of thrown sort of more and more work because we don't have colleagues that can you know, that can be like, you know, that can be culturally and linguistically sensitive, and because our organization is marketing and recruiting, and with the Affordable Care Act, we're taking on more of those patients, but we're not getting more of those providers, and actually some of those providers are leaving. And instead of really facing reality and keeping it real, which is actually the sort of the phrase that the Diversity Inclusion Symposium that Kaiser put on the last few days is actually keeping it real. But instead of keeping it real and finding out why is it that we're losing Latino physicians from this organization, instead of that, we're saying, well, we're great, we're the best, and we're going to start this medical school, and it's going to be awesome and innovative, and it's going to help us to reflect the diversity. We'll see that, you know, remains to be seen, but. I think that in terms of the journey, it's really difficult to be in that race every day, that sprint, especially when you don't feel like you have the support of those around you necessarily. In some ways you do, in some ways you don't. So I was going to just speak to another sort of analogy that made me think about sort of why I'm here with regard to teamwork. And I was at my daughter's race yesterday. She's a freshman in college, and she was in her first in West Coast Conference in CAA Division I championship race. And these are teams racing with teams that are ranked, number 3 on the West Coast, University of Portland, number 7 in the nation, BYU. These girls are fast. I mean, they're super fast, and it's crazy looking at them running. And so I was watching my daughter, and of course she's not, she's struggling to keep towards the back of the pack. And when she finished, she told me that, she's a very positive person, so she was happy and just joyful to be there as a freshman and all that. But her teammates, her captains, as she was struggling to kind of keep up there, and in the last, 1,000 meters or whatnot, she told her senior teammate, come on, let's go. This is your last conference race. Come on, pick it up. And her teammate, she said she felt bad because her teammate, her captain, said to her, "I hate this," and so my daughter said, she really relies on her teammates, and I think I do too as a practicing physician. So it really feels bad when you have a team, your captain, your mentor is telling you, this is, I hate, why am I here? I hate this. So anyway, so I guess you can look at it on the bright side and say, hey, I'm going to be positive, and I'm going to, I think I can pick it up. And my daughter did pick it up, and she passed her up and finished before her. But I think for me personally, I feel at this point in my career that I need to be in a place where I see that there's a transformation in healthcare. There's huge opportunities for those younger populations, and I would like to see those students who really are passionate about serving the communities and really care about being a caregiver. As providers, we are caregivers, and it's not easy work, but it's very rewarding, and I love it. It's fulfilling in that way. But I think we need more of those positions to come into to the ranks, and I think that's one of the reasons why I'm here, is to try to help see to it that that we do bring those students on board and work to try to clear the pathways for them and help them on their journey. So Kaiser, calls this vision of theirs equity and inclusion for all a journey and an evolution. It really is, but it's the same kind of journey that all of the other people here on the panel are talking about. We're in different places, and we're serving slightly different populations, the majority of which are all Latino, but at different levels and whatnot. But I think it is still a journey. So, I think that we all have a lot to bring to the table. So I'm really excited to be a part of this movement for change. I will show you a couple things about Kaiser that we are doing. I think because we are the integrated system that we have some advantages in terms of the resources. There's a lot of duplicative, resources, I think, but it does, I think, help in terms of the outcomes. Of course, all of our patients are insured. That helps too. They have different levels of challenges nonetheless, and that's probably one of the reasons why we still have CR disparities too. They're not quite maybe as big as they are on the outside. So if we just advance, I don't know if I can advance myself because I'm going to go forward. This is go forward. So this is the demographics we've already seen. The Kaiser Southern California demographics, we have the same problems that the state has, for sure, with some slight differences. This is our Los Angeles Medical Center where I'm at. Other areas I wanted to give you, of the 13 areas that we have, other areas, Downey, which has probably the largest Latino population, the medical school demographics again, and these are residency match demographics. Kaiser has 234 residents and fellows across the region. Most of them are actually at LMC, not across the region. There's more across the region. But this is across the region. And in terms of how to get more residents onto our, into our programs, I just wanted to show you some changes in the demographics just in the last year. For Latinos, I think it's all about relationships, familia, confianza. I think that, I came to the table again just very recently. Over the last couple of years, I've been doing nothing but thinking about the physician shortage, and that's why I'm here, because I did a fellowship with that Kaiser started because of their need to, with the medical school, to contract with outside partners who can help them with the accreditation process. So my mentor for my fellowship, which was looking at workforce and shortages, as dictated by the Kaiser partnership with George Washington University's health policy, and Fitzhugh Mullen, who started the social mission of medicine movement, and he's what was referred to as a rock star in the AAMC, the American Academy of Medical Colleges, but he's not necessarily well received by the ranks of the executive leadership there because of his vision of medical schools being accountable for the physician shortage, and them not necessarily seeing it that way. But he wrote a paper in 2010 that showed, that ranked the medical schools and turned the climate, the political climate in the AAMC upside down, because he, in contrast to the rankings by U.S. News Reports and whatnot of medical schools, his ranking looked at how many primary care doctors they train, how many underrepresented minorities do they have in their schools, and how many of those doctors, regardless of their ethnicity or race, go to practice in underserved areas. So he ranked the schools based on that, and the top-ranked schools went to the bottom and whatnot. So he was my mentor. We did nothing but talk about physician shortage for the whole year in 2015, and that's why I'm here, because my fellow colleague on the fellowship referred me to the board, Juan Guerra, who's the only Latino sitting on the Kaiser School of Medicine core curriculum right now. But in terms of relationships, when I came on board to do some work with Kaiser and with the help of Frank Mesa, who's done amazing things, along with Tina and others, Maria Corasco, who's on the National Board of Diversity and Inclusion, to help Kaiser in their efforts, bring language concordance in, put language and ethnicity on the in the electronic health records. So between 2014 and 2015 and this year, the current students for Latino students at our residency program increased just because of the relationships that we established in our culturally responsive care, and myself reaching out to those students and trying to build relationships with them and help them to feel comfortable, coming on board to Kaiser. So just looking at the language concordance program, I think that's one of the things that Kaiser really talks about doing differently from other organizations, is being able to track language. Frank Mesa's efforts were finally realized after many years of struggle, he tells me, and we do track that, but do we track other things in terms of how we do with the following the class regulatory requirements? That's another story. So I think that was one thing that I was discussing here with Camila regarding what kind of things that we could do as an organization to mobilize political force in our communities, even potentially to move the needle in terms of the pipelines. And I don't know if this is something that we can do, but we have these federally mandated regulations around culture and linguistic quality care, and we're not really held accountable to them to any sort of degree that I think is sufficient. And yet they are, it is law, and so this is under civil rights and Title IX. And if we were to empower our populations and advocate for their voice, to hold up hospitals accountable, healthcare organizations accountable, to to honor this, then perhaps they would be required and more accountable to hiring physicians and healthcare staff that were culturally and linguistically sensitive to the populations they serve. Perhaps this would be a way, if we can push our legislation to have hospitals and healthcare organizations be held more accountable for those types of things. And that's one of the things that Kaiser's committee supposedly for the medical school are discussing is, do we want to require a language for those students that are coming into the medical school? Do we want to provide language assistance? Required language should be required native language as one of the criteria for admission, and that would probably help a lot in terms of admitting students that we want to represent our community. So just a lot of thoughts that I wanted to let you know. I don't want to take up a long time. So yeah, I just wanted to let you know in terms of Kaiser, the impact of language concordance. There is an impact of language concordance on our quality care, diabetes, blood pressure, colon cancer screening. The differences in the bars look like, but because of our large populations, it's on the order of tens of thousands of patients who have better control in diabetes, better blood pressure control, and better colorectal cancer screening control for those patients that are with concordant physicians. And there's a lot of other factors that are probably not taken into account in terms of which of those concordant physicians are actually not just bilingual, but by culture and whatnot. So there's a lot of those things that we look at on that. And that's the same thing with the disparity data by race and ethnicity in our population. And just in terms of how we're doing compared to the rest of the for HEDIS measures for the rest of the country. These numbers are really high. So for diabetes control, less than 9 and 8. I mean, the numbers are in the 50s and 60s nationally average. For blood pressure, it's about 20% lower. For colorectal cancer screening, it's in the 50s and 60s. So, I think that largely speaks to the integrated system that Kaiser has with colorectal cancer. This was a study that was published by not Kaiser, but an external researcher from Stanford, actually a couple years ago, showing how, looking just at integrated healthcare systems in California by mortality data for colorectal cancer, and showing that within an integrated system, that was the Kaiser system they looked at. They looked at data from across the state, that actually Kaiser eliminated disparities for mortality from colorectal cancer because of these three factors, and these are the quality factors that are looked at in terms of mortality for colorectal cancer. Whether they have surgery in a timely manner for their cancer, whether the correct number of lymph nodes are removed, and whether they get the proper chemotherapy in a proper amount of time. So because of those, the yellow side, the integrated system being utilized, they were able to eliminate data. So the integrated system obviously can do some positive things with eliminating disparities, but we have the same journey as everyone else. We have a lot of barriers to overcome, and I'm hoping that we can work together as partners to try to tackle those issues.
So great. So we wanted to thank you so much for opening it up for question and answers, and we'd like to, make sure that we have an opportunity to continue now. Just so you know, our program says 2:30, but our advertisement says 3 o'clock, so we fooled you. That's pulling another card out. But because we do have a lot of opportunity for discussion here, so yes, Tomas.
So thank you all for that information. I wanted to kind of address the notion of primary care workforce. And I appreciate, Dr. Flores, you mentioning kind of the notion of nurse practitioners and PAs as well, because, primary care physicians, nurse practitioners, and PAs have been identified kind of as the resource for addressing some of our primary care needs. But your data on the NP moving to private practice is fairly sobering. And from an anecdotal standpoint, when we review PA applications, the lure for many of the applicants is the flexibility within PA to specialize, right? So I'm personally, not anecdotally, seeing a lot of folks going into PA because there's this emphasis on primary care. So the problem is this, kind of the elephant in the room, and it's this notion of kind of the perceived impalatability of primary care. Right? We know that primary care programs, residency programs, are not being fully met. The matching is not happening. We talk about increasing primary care programs, residency programs as a solution. And it all relates to the complexities of some of the data Dr. Hernandez talked about the decrease in behavioral health workforce. Primary care providers are being asked to do a lot more. The integration of behavioral health, advocacy, patient navigation, and so forth. And so, as in the words of one of my colleagues, who said primary care is not for the weak, it's not for sissies, because it is very, very challenging to do. You have a wave of young people who are coming into medicine where work-life balance is a priority. And we talk about it all the time. And many of them are not perceiving potentially that primary care is going to allow you that work-life balance because they're hearing this. So there's that challenge we're facing, right? The perceptions that primary care is maybe not a viable life work balance. Now, sorry for my long-winded question, but we know that there are very innovative positions, community health workers, promotoras, health educators that can play a role in taking some of that. And they're actually really viable employment opportunities for many of our Latino community. But many of the safety nets and organizations cannot use this because they are not reimbursed positions, right? So who is missing at this table is the third-party payers who can kind of change some of that dialogue, and once again, they're not here. So I was wondering if you guys could just comment in your thought about kind of the perception of primary care in the up-and-coming workforce, as well as we have solutions, but there are obvious barriers. Sorry.
Okay, well, I can, so this is a huge issue for the community health center, so I'm happy to address this. So one of the very important aspects of this is the team-based care model, which is not so physician-centric. And it's something, one of the great things about healthcare reform, it actually embraced this with the patient-centered medical home becoming one of the concepts in healthcare reform, the emphasis on primary care and more looking at a team-based model. And this is something that the health centers, we haven't been able to be physician-centric for a long time. I mean, for many, many years I've been going to community health centers and seeing PAs and NPs and the fact that they're looking at having other providers. But one of the challenges that we face is that, as was alluded to by Dr. Flores, is that our payment model, which is visit-based and provider-focused, excludes the whole range of providers that should be part of the optimal team in a primary care setting. So one of the ways that, again, being bold and proactive, which I think is a hallmark of our association, is that we chose to craft a payment reform initiative that would free us up, and this would, in the context of FQHCs, which, if you're aware, are reimbursed on a per visit basis. It's called the PPS, Prospective Payment System, and so you are reimbursed on a visit basis. And so we have upended that by introducing legislation that we help to define a new payment model, which is actually a capitated payment model. And it's a PPS equivalent. So the community health centers are guaranteed what they would have received under a per visit model, but in the form of capitation. And then they are freed up from all those things that disincentivize everything from group visits to same-day visits to email, mobile care like at Kaiser, to being able to use promotoras. So they will be receiving a capitated payment, and then they will be able to decide and should enhance the team-based model of care, as well as allow for other modalities like, how about off-site visits, which we currently cannot be reimbursed for. So this was an initiative, and there was definitely some pressure from the state because we have been under pressure for over a decade about the PPS system. And then the ACA kind of pushed it even further with the emphasis on value-based care. So we saw it coming. Payment reform was in the wind. We knew that it was going to happen. And so we, working with Senator Hernandez, proposed this legislation, which, by the way, didn't go through the first time. It actually didn't go through until we found a partner, which was LA Care Health Plan, to co-sponsor the legislation with us. And then we were successful at getting the legislation through. And so now there's going to be 60 pilot sites minimum in FQH, and there'll probably be more because the application will be going out in the new year. They'll probably come out of the woodwork of community health centers who are ready to experiment with this new model. So that's one very important piece of the puzzle, is to acknowledge, at least for community health centers, that our payment model has not incentivized. So we use promotoras, but we've looked into it. Those are grant-driven programs. When the grant runs out, they go away. There's been a lot of challenges with sustaining these kind of providers in community health centers. So now, with the payment reform, that is one way that we are going to be able to address and enhance team-based care. But I think what you are saying is so important about the challenges that primary care providers have. What you said about more behavioral health demands has been the case for long time, over a decade, as county mental health systems basically have fallen apart. More acute mental health types of individuals have been showing up on our doorsteps, and community health centers have had to serve them, and primary care providers, because we don't have enough. By the way, not to complicate it further, but for the last 20 years I've been at the association, MFTs were not allowable providers for FQHCs. And we only changed that. The governor just signed that about 3 weeks ago, a bill that we finally got through that will allow for that. So we've had just so many barriers. But so the team-based care and payment reform is one, but addressing this issue about the challenges on primary care providers is absolutely critical for a whole other reason, which is retention. We are losing our primary care providers to places like Kaiser and other providers because of some of the challenges and demands of our complex population. But yet the data shows, and some of the UCSF data shows, that physicians who work in an effective team-based environment are actually more satisfied. So that is something that we really need to glob onto and really evaluate and dig deeper within community health centers about those challenges and barriers that our providers are facing and what we need to do to address them. So salaries are going up in within our constituency because we can't retain the doctors unless we increase the salaries, but that's not enough. It is about the work-life balance. It is about how they practice medicine. And we've got a lot going for us because of that team-based model. So if we can just tweak it, get it paid for the correct way, that could help us address this satisfaction kind of issue. And I'll tell you, health centers, another way they're having to adjust with the work-life balance, part-time. New providers are not working full-time. If we want to attract them and hire them, we have to be flexible and provide part-time. And there's a lot of women coming in from the medical profession. They do not want to work full-time. And I'll tell you, there's been tremendous flexibility and change in the community health centers because they have to. But the other flexibility, too, is not just focusing on the physicians and looking at how they expand the team and maximize the care that other members of the team can provide, too.
Can I just break into this for a second? How many of you have heard of MACRA? Not micro, but MACRA. Good, okay. So MACRA is a new federal legislation. CMS is now putting it in place, and it's a payment system reform that's moving forward, and it's payment system reform on steroids. And it's really moving away from the traditional fee-for-service model where you pay for one unit, and it's about the more you do, the more you get paid, irregardless of the outcomes. So the MACRA is the federal government is transitioning. You can't continue this perverse, and I'm saying perverse system of paying for more widgets. We've got to focus on the outcomes. The healthcare system has to pay for quality. So this is the transition that we're seeing. It's not an experimental model. It's a way of payment reform that's going to continue. So within MACRA is the transition that's going to happen in 2017 into the 2020s, where the payment is going to change such that we will now be responsible for outcomes of our patients. And that will transition this, give us this opportunity to address some of those issues and about how we can look toward setting a system where it's about team-based care. It's about not just the physician doing the work, but actually a team, pharmacists and social workers, and it's about the whole healthcare process, and it's about pay for outcomes. So, if you haven't heard of this, you need to get on the bandwagon, because this is going to start being the way that healthcare system is going to get paid for in the next millennium, and it really will. So in there is mechanisms to pay for advanced payment models. So there's two pieces. I can't spend the time because we spend like 2 days here. So in MACRA is something called MIPS, which is a merit-based payment system, which joins the 3 major programs of the new program on quality or innovation, and then the second alternative is advanced payment models, or alternative payment models that have with them the ability to do bundle payments and payments to these primary care or patient-centered medical homes. And so as we look to see that transition, we're going to see that this is really going to drive the ability for us to not just, worry about, the widget piece, but worry about getting quality outcomes. And it's going to be a tremendous boon to the system. And it's going to be a whole changeover of the way that we, as physicians, are currently seeing how we get paid. So stay tuned for more.
Yeah, and whatever Medicare does, there's an old adage, whatever Medicare does, everybody else soon does. And but in California, we're actually already ahead of the curve. Capitation, the Kaiser style. I trained at Kaiser and learned how to deal with prepaid dollars and how to make the wisest investment of those so that you actually get the best outcomes. And when we established our practice in East Los Angeles at White Memorial, we did exactly that. We said we're going to emulate everything that Kaiser does. At that time, Kaiser was really struggling with how to take care of Medicaid patients, Medi-Cal, and the uninsured. I think Kaiser's not grown to over 1 million Medi-Cal members, right, statewide. So it's definitely into the mainstream is the Medi-Cal population. But what we learned was the capitation and getting those dollars and making a wise investment of those. And the reason that's important is that, getting back to Dr. Magaña's question, we learned that the Kaiser model, the group health cooperative, the Harvard Pilgrim, Intermountain in Utah, all used a balance of primary care and specialty care as the secret sauce for their success. And you had 50-50. At Kaiser, you have physicians, nurse midwives, nurse practitioners who will augment that primary care to that 50% level. The ounce of prevention is worth the pound of cure. And they use their hospitals very efficient. I was at a conference 2 years ago, they called it the ACO Congress, and Bernard Tyson gave a speech about the Kaiser model. Jamie Robinson, who's a faculty member at UC Berkeley, came after him and he said, there's 400 hospitals in California, acute care hospitals in California. If they were all managed like Kaiser, half of you would close. Now there was all these hospital executives looking at each other and all freaked out, and he was provocative, but he was, to a large degree, correct. Our hospitals are set up to be inefficient. Well, the primary care day has come, where Kaiser is a great calling card for us. You've heard a little bit about our recruitment. We recruit from the community. Statewide, we're the #1 program recruiting Latino and training Latino physicians, family physicians. And Kaiser has discovered them. And Gilbert, the recruiter, told me that he is required to meet with our residents twice a year. The first year is to give them an orientation to Kaiser. It's a nice dinner so they all get to meet each other. And the second meeting is contract in hand. Because the way we train our doctors is they have no fear of Medi-Cal. They have no fear of managed care. And they have no fear of taking leadership role in the care that they're going to deliver. And that's really the greatest calling card for us, is that Kaiser really appreciates how we train our physicians. The second piece to that is payment. Kaiser is now paying family physicians $250,000 a year to start. And a signing bonus, if they have to relocate, $50,000. One of our graduates just came to Sacramento, $250 plus $50, plus he's eligible for loan repayment of $200,000. That's hard to beat. And I don't blame Kaiser. They're just a messenger for a very tight primary care market. So I think we're seeing something changing now to bring primary care to the same level, at least in those systems. Number two is that there's this whole issue of burnout, that we're hearing about physicians. And as we study that issue, behavioral scientists tell us that Burnout and stress are directly proportional to how little control you feel you have over your career. So empowering our residents to be leaders, to design the type of practice they want, and to emulate what Kaiser does well, which is the group model. Doing a solo practice is an impossibility, except maybe in a rural community. That's out of necessity. You have to be organized into groups. The strength in numbers, the efficiencies, the life balance, all the things that emanate from that. And the flexibility that Carmela talked about. You know, in the US, more than half the medical students are now women. And when they graduate, you know, God still asks them to be biologically the ones who carry babies and all of those things. And we need to be flexible to that. Now, we've had physicians, female physicians who've been here with us 20 years. And guess what? When their kids grow up, they come back full-time, and they're the most loyal providers, and they've already built a base of physicians that rewards us for having given them the flexibility they needed to be a mom during their childbearing years. And quite frankly, 50% of someone who's part-time, who's totally committed to what we do, is worth 100% of someone else who can care less. So from all those perspectives, flexibility is paramount and really key. And the team-based care. You know, necessity is the mother of invention. When you're working with poor people, and the community clinics are the best example of that, you get creative. And you find better ways to do it better, faster, cheaper. And thank God with capitation, all of that gets rewarded. So we've been training promotores since the year 1998, and they're part of our workforce. And they are actually able to connect much better with our patients in ways that we can't, and they have the time to be able to do that. So we call them the local neighborhood commodities. You know, they're the ones that the patients trust. Pharmacists, we just haven't executed an agreement with our USC School of Pharmacy, so their pharmacists are going to staff our clinics and help us manage populations. You know, we've had navigators, we've had health educators, we've had social workers. All the things that patients have is, as we know, the best value for them is also addressing the social determinants of their health, and getting outside of the four walls of our office is as important and sometimes more important. So empowering the clinicians to be advocates in the community is critical. And that's why joining the FQHC family for us can't come fast enough. And this is really a great time of change. So, you know, let's kind of keep these things in mind. Healthcare is in transition, but I think some good things are happening. And, you know, if it's lemons they're giving us, let's make lemonade.
My name is Lemon, first name.
That's right.
So, what do I tell my students? What do I tell my doctors who I'm looking to come and take my place when I leave a very successful practice to try to develop a system to get them back to my community, provide the kind of medicine that I want, that I came into medicine for, more Marcus Weldon type. I know it's corny, but like as I was telling the lady earlier, my wife just had a knee replacement as a Kaiser. I'm a Kaiser, I love Kaiser. And she had and I'm going to have that same knee replacement, the same doctor who examined me a few days ago. And he was great. Even though he kept it back to me about 67% of the time. And also his conversation was like, we can get a robot call, you know, in terms of, you know, he's a great technical person. But it was like the soul. And my practice is good as soul. I don't want to lose that. I want the patient to have a choice. So up there on that panel right now, I'm not that. You understand? And there's no mechanism. What you're telling me is basically, you know, LQHC is great, that's where you need to go. So what if I tell my, forget about coming out to me? Just that my practice down the line and my other doctors, where are we in this process?
Great question. I think there's two pieces to that transition. One, the uniqueness of the small practice for many communities, you make yourself accessible because you're right at the street corner where they can make it. And we don't want to lose that. But I think what we need to do is your transition plan would be to start talking to 2 or 3 physicians who are coming out of residency program to take over your practice so that they can have the life balance and all the other sustainability that they need, but still keep that location convenient. It's paramount for folks to learn to be more efficient, and the solo practice has been highly inefficient because, you know, there's just so many things you end up doing that somebody else could do far better, but you don't have the resources to have them do it. So I would say your transition plan is really start recruiting not just 1, but 2 or 3 physicians. Now, it may be hard for you by yourself, talk to 2 or 3 other colleagues that are also looking at their horizon being the next 5 or 7 years or 10 years, and start talking to them about coalescing that practice so you can recruit those 2 or 3 physicians to take over 3 or 4 or 5 solo practitioners. That would be the first way to start. The second, if you have the wherewithal and the opportunity, start merging your practices now. You may actually find that you'll be working smarter, not harder, and that you'll actually be able to extend your retirement a lot longer because you'll be feeling less stressed in the process. I look at in East LA, or those of you who are familiar where we are, on Cesar Chavez between State Street and Gage, there used to be 32 clinics, it's a 3-mile stretch. A lot of very busy physicians, all reinventing the wheel, overhead, the same thing. If they had formed a 32-person practice, they would be so much better off and their patients would be so much better served. So it is a time for us to consider things differently. I'm not saying you should change that because you're looking at your horizon, but start talking to your colleagues who have the same horizon and start recruiting those 2 or 3. And you know what? Hospitals right now are highly motivated to help you with that recruitment.
I appreciate you raising this issue, and it's something, I think there's an analogy with what you're dealing with as a smaller private practice with maybe some of our smaller community health centers are dealing with as well. And sometimes I also think about the future of like the Planned Parenthoods as well that have a more narrow kind of scope. And what is their future? And so I think the challenge, there was a time like 10 years ago as the Statewide Association of Community Health Centers where the word merger, M, was a bad word and I couldn't utter it. And then in the last 6 years or so, with actually after the ACA and our strategic plan, the health center said, we need to start thinking about mergers. And it actually became something that was okay to talk about and that they were asking for resources on, and they wanted to advocate with the feds on some of the barriers that they were facing. So I think you gave very sage advice in terms of private practice. I think the CMA is probably your best advocate for your future because they still seem pretty wedded to wanting to maintain that, and I give them credit for being loyal to their constituency. But they, I also hope that they're thinking of helping you with this very question as well, because is that model really going to be viable into the future? And I think we have to ask the same thing within the community health center world too, in terms of the small, because we have the whole range from community health centers with $100 million a year budget to down to tiny little community health centers with one physician, and everything in between. And some of those smaller ones, especially when they're isolated, or particularly in rural communities where the patient population is not growing, or in fact they're losing population, that they're struggling with these issues about how do you remain economically viable. And like for us, we have to look as community health centers, I think we might be in a position to look at things like maybe a special investment for rural providers, or I think because we're nonprofits, we might be able to get the government to look at certain sustaining things that they could do to help buttress. I think the private practices aren't necessarily going to have that kind of support from the government, and so I think it is really important to look at how that model needs to evolve.
Yes. Sarah, and then.
Well, I think the whole medical system really needs to be revamped because a lot of the flexibility isn't there. I guess my interest in continuing with, our discussion is really looking at how we continue to increase the pipeline, because I think what happens right now is the 5% is shifted from place to place to place, because you don't get rewarded for years of experience unless you're a partner somewhere. You get rewarded for going on to a new organization and getting an sign-in bonus. And right now, a person coming right out of residency can actually make more than I made with 31 years of experience. So, I think that, again, we can talk about the different ways that we shift to 5%, but really I'd like to see our focus be how do we get at least 7%? Or 6%, that's what I'm committed to. They're the future. I'm on my way out. So.
Well, great question. I think part of it is some of the programs we talked about today. Part of it is just looking at any entry-level position as a portal to a future career. So in our group, as I mentioned earlier, we provide our employees scholarships, and we've had several MAs who have now become RNs. And actually, we lose them to the hospital, but that's okay because they stay in the area and they become great ambassadors for other human resource for us. And they serve our patients really well because there are case managers in the hospital, et cetera. The other piece is we got to break the doors open on the international medical graduates. You know, there's a lot of IMGs already here. We used to worry about creating a brain drain in those other countries, but they're already here. And part of this is because their native country doesn't have an infrastructure like we do with Medicare or Medicaid for dependent populations. They don't have that kind of infrastructure, so if they can't make it there, they come here. And sadly, they're driving taxis or not Uber, I guess, but you know, those things. So we need to really reach out to them. Also looking at physicians who are thinking about retirement and helping them transition by working and brokering the partnerships they need to make sure that if their practice is viable and they can sell it, or that they can merge with other physicians and get the technical expertise they need to accomplish that, to become much more efficient at what they do. So we keep them a little bit longer. And then the other piece is really looking at working with the institutions, all these sort of rate limiting steps, if you will, to be able to create that change. We've had a long-standing relationship with USC. Several of us, as you may recall, serve on the admissions committee. So when we're recruiting students through college, we're going to be their advocates at the medical school level. Luckily, Dr. Raquel Arias is wonderful, and she's the chair of admissions. So, you know, USC has been the leader in terms of minority admissions for many, many years. Someone mentioned that earlier, that the UC systems are much more rich. So we need to do all of these various components to open up the doors of opportunity. But I think a ready workforce is the international medical graduates. They don't necessarily are prepared to be physicians, but with a little bit of fine-tuning, they can become physician assistants or other kinds of fast-track licensure pathways.
You know, I totally agree with you. This 5% is just completely for the birds, and it needs to be such a higher number. And so I've been trying to think in my mind how we just have to elevate it to a whole other level, and that's why it can't just be about physician. This is an equity issue, and it's a workforce issue, and this is about the future of our Latino community in the state of California, and whether or not our children have access to an adequate education like STEM and computer programming and all that, because it's not only the issue of getting access to these growing job workforce in healthcare. Well, let's talk about the tech industry, where I'm from, San Jose in Silicon Valley, where we're 5% of the tech industry that is located right in our backyard. And not enough is being done, you know, in those schools to generate and provide those children with the education where they ultimately have the opportunity to secure these jobs. So this is a bigger issue, which is why we can't just think of it as the physician issue. You know, we have to think of it in a more broad base as a workforce issue, as an equity issue, as an economic opportunity issue for the future of the state of California. So, you know, we need to look to our civil rights organizations like MALDEP and NCLR and some of our national long-standing organizations to elevate the broader workforce issue as well. So I think that's how we break beyond the 5%. It has to be elevating at that level. So I don't know the exact answer of how to do that, but I think that's what ultimately needs to happen so we can get beyond these crumbs that were being thrown.
Hi, so I am a proud Kaiser Permanente physician for 26 years, and we have 5 community health centers in Western Ventura County for the last 10 years. I work in a community in Oxnard, of which I was born and raised, and I'm kind of fulfilling my dream. And we have about 70% Latino patients, all primarily Spanish-speaking only. We have a 70% concordance language match with our patients, so we're really proud of that. And I wanted to share a little bit about the challenges that I've had as a physician leader, of which I'm the chief of the department there, and that is of hiring physicians to fulfill that. There's not enough. So I've hired 6 doctors in the last year and a half. 2 of them have been foreign medical graduates from New York, so I feel really fortunate to have them come join. One has been a DO, which traditionally we haven't had a lot. Again, great doctors, young, enthusiastic, lots of energy. We have a team-based model where we work as a team. Someone mentioned earlier what we do at every encounter is what we call complete care management. So when we have a patient come in for an ankle sprain, our electronic medical records can automatically populate when was your last tetanus, when was your last mammogram, when was your last PAP, when was your last colorectal screen. So when they come in, they're coming in for their ankle sprain. My nurse already populates all that on the order, so it doesn't cost me more than 3 seconds to sign the order. If the patient is willing and open, we have them undressed from the waist down so they can get their pap smear done in urgent care. And we try to get complete care management so they don't have to come in for their physical, okay? So that's one thing that we've done. The other thing is that we can't do this on our own. I've hired as many, mid-levels and nurse practitioners and PAs, so I have hired a pharmacist. And a pharmacist helps us deal with all our hemoglobin A1Cs greater than 8. And she's doing a phenomenal job. Now, she doesn't speak Spanish, but she's very culturally sensitive. All our staff, most of them are Spanish speaking, not all of them, but for those who don't, they use the language line very, very efficiently so that our patients, from the time they're getting their vitals done, are getting their service in the language that they feel most comfortable with. And so really, what I feel like we've done in the last 10 years in Western Ventura County is work as a team, because we can't do it on our own. I'm very fortunate to work for an organization that has been very supportive of my endeavors. And what I've done in my little, Oxnard, California, is I started the Hippocrates Circle program out there. So I have a budget nearly of $10,000 where I can mentor young junior high students. And then I said, well, what are these kids going to do afterwards? So I call up Region, I need money, we're going to start a summer volunteer program. So our summer volunteer program is almost 9 years old. So those same kids come in and work in our clinics. We not only get them from HCP, but we get the patient population. We have over 6 local high schools in our community that we have flyers in the exam rooms, we have flyers in the reception, come volunteer. And then we also have a paid internship program where underserved kids can come work in our clinics. So I think that we're doing a lot as an organization, but also out in the community. I consider ourselves to be a community health center because we don't have a hospital out there, okay? We don't have a hospital out there, and the way medicine's going is the primary care physician, when I trained many years ago, we did urgent care, we did hospital care, we did grounding, we did it all, we did critical care transport. We couldn't do it anymore, and so now we're realizing we can't do it anymore. So now we're having an urgentologist team that focus just in urgent care, hospital care, and what we do is we actually partner with local community centers. We have a Clínicas del Camino Real out in Ventura County, so we go out there and we partner with them with health fairs. We've partnered with a local hospital, Community Memorial Hospital, where our physicians are working in that hospital, our hospitalists are in there. And it was very hard 10 years ago because a lot of people saw us as a competitor, and that's not what we're about. I mean, we're about partnering. We're not out to put people out of business. We're out to partner and render health care. And I think really that is the premise and mission of Kaiser Permanente, is to partner with the community. So I just wanted you all to hear a different perspective, because I've had a different experience in that it's all about, partnering, reaching out. Our physicians are training, the county residents and even the community hospital residents. As you all know, that many of the UC medical students are training in our hallways in our hospitals, their 3rd and 4th year. And many of our retirees and our own Kaiser Permanente physicians are actually teaching in the medical centers in their CCM classes. So I think that the message I would like to get out there is that it's all about we, and those little of us that are in small community centers. There's a lot we can do in our local communities, because sometimes being out in Ventura County, we're removed from the LA Basin area. And practicing as a Latina physician for 26 years, this is the first invitation I've gotten to, attend a meeting or a symposium outside of Kaiser Permanente. And I'm here, I'm willing, I want to mentor, I want to hire, I want to recruit. And I have had a lot of students. Anybody who knocks on my door, I'm here to help. So I just want to, send that message out there that I think that's what it's all about. It doesn't matter if you're from county, UC, state, or whatever. Let's just all pull our resources together and, make a think tank and work for the same cause, united.
Thank you for the a great example of how Kaiser evolves as well and allows its doctors to innovate. A couple of things about the future, because you are the emerging workforce that will have to deal with this headache. In 2030, the elderly population will double to over 70 million. And the number of workers supporting the Medicare that they will receive will go down from 8 to 1, which is already inadequate, down to 4 to 1. And in 2040, we will hit 100 million people who are over 65, with 3 workers for every. It'll not be sustainable. So we need to look for better ways to do this much more cost effectively. That's why Kaiser is looking at using mobile technologies and other telecommunication to reduce the demand of their face-to-face services. But all of us are going to have to do this. And to Carmela's point, I think the future should be a physician-led organization. And it only speaks to, not because I'm a physician and I'm a physician chauvinist, but because of the training we get allows us to be able to look at the big picture and the planning. Physician-led, but not physician-centric, because the majority of the care will be provided by non-physicians, because we just can't produce enough, number one. And it's not cost-effective to have physicians doing things that somebody else could do far more competently for a lot lower cost. And those partnerships are a classic example of where we need to go.
So,
another former LMSA member?
Yes. So, I wanted to make a comment in regards to the Latino physician workforce and diversifying the workforce. I went to UCLA, CCN, the LMSAs. I trained in East LA. I am a gastroenterologist practicing in East LA. And it's become a really difficult task to do. I see all the great work that Kaiser has been doing regarding, increasing physician workforce and, for example, colorectal cancer screening and so forth. But, I wanted to pose the question to, when we talk about diversifying medicine, let's also not forget our subspecialists. We really need to work in partnership. The community health centers out there, you want to increase the number of NPs, PAs, and primary care doctors that want to work in this area. But what about partnering with some subspecialists in the area that can provide and maybe pick up that burden of specialty care in the community? Let me tell you, just to take the GI aspect of things, I see data for colorectal cancer screening for Kaiser is 80%, which is great. Let me tell you, as a GI society, our colorectal cancer screening rates in terms of colonoscopy are about 40 to 60% nationwide, which is horrible. And then when I was graduating from fellowship and I was looking at, where do I want to practice, and I was looking at, okay, well, I want to practice in the Latino community, and then I look at the number of Latinos that are graduating from fellowship, it's 7%, which is horrible. I look at the number of African Americans graduating from GI fellowship, it's 3%. And most of the other graduates are either Caucasian or Asian. And then I have a friend who's a plastic surgeon who's also Latino, who wants to work in the community. And we were discussing this one day, and we're like, well, what are the numbers in the other subspecialties of the number of minorities that are graduating? And the numbers are the same. The numbers are about the same. And then of course, we have to ask ourselves, well, okay, so we're not graduating enough minorities that want to practice subspecialty care. But then how many of those minorities actually want to practice in East LA or want to practice in South Central LA? Let me tell you, it's not that many. And I'm having a difficult time myself because I'm in a group practice, and by group I mean just 2 physicians, me and the other guy. Okay. The other guy is 30 years older than me, about to retire, leaving his practice, and I'm thinking, who the hell am I going to recruit? Who's going to do all this work? Who's going to do all these colonoscopies for colorectal cancer screening? When 7% of the Latinos are graduating, and a lot of them are taking probably more lucrative jobs out there because they don't want to practice in East LA. So that's a question that I want to pose for everybody, that, let's not forget that we also need to diversify subspecialty care in our community.
Absolutely, and the global approach to this, if we look at, in 2015, we're finally adding up the numbers, we spent over $3 trillion on healthcare. Much of that was wasted effort and wasted dollars and went elsewhere rather than patient care. We need to organize ourselves, and this is where the group's practice, the group's strength, the strength in numbers to negotiate that. We got to organize ourselves to draw down our fair share of those $3 trillion so that we can invest that in better care for our patients and the viability of our practice. The other thing we talk about, life balance, family responsibilities. Most of us in this room, I'm sure, grew up poor, so we were eligible for financial aid, right? But all our children are now a doctor's kid. So we got to put some money away for them to get educated, because they're not going to get need-based scholarships. And so we need to be able to also look at the life balance of our family and these other issues. That $3 trillion is not disappearing. It's still there. So we need to organize ourselves in such a way that we draw down our fair share. And it is possible to do that. These accountable care organizations, these integrated delivery systems. Part of our generation, my generation, not yours because you're a lot younger, Don, my generation was recruited into medicine to be an ardent solo practitioner. And that mentality, for me, thankfully, as a Latino pre-med, was different because of the pre-med organizations and the teamwork that required. And then working at Kaiser, I trained there, I was a partner. The wisdom of the strength of the group for me ingrained in me already. But for a lot of docs in my generation, they're still ardently trying to be autonomous, even if it means their death as a practice, right? We need to change that. Fortunately, the new generation is getting it. What you're doing today is there's probably a couple of future GI docs here and say, I want to join that guy because he's got a mission to serve the underserved and he's going to need my help to do that. We need to do more of this, obviously, but it's really the strength in numbers that gets us to that point where we can negotiate the right kind of practice that we need for our patients. Dr. Baker.
Yeah, so I just want to make a comment about people want. I'm an ophthalmologist, so they're one. So, but going back to that, and again, I think this is in part a consequence of the fact that we are not setting the agenda and setting policy. Because again, even though I'm a proponent of the ACA was built on the assumption that the problem was special. Right, oversupply of specialists overspending. I don't think that's the assumption. But anyway, the things that are being done in order to save money, whether it's narrow networks or whatever, it's all about controlling specialists. But the reality is, in underserved communities, that's not the issue. Right? At those qualified clinics, everyone else, where everybody's saying, well, we can't get any specialty care, even if we had appropriate primary care, and we don't, it's underserved. The specialty deficit is even more. So again, I'm sure there, for those particularly solo small group out there, and even S2HC, physicians are in the situation of holding patients. They're just holding visit after visit because they can't send them to a cardiologist, they can't send them to wherever it is out there. So the real issue is, I don't think it's that people don't want to do that as a specialist, because I do and others do. The fact is, you can't do it because the system is not set up to allow you to do that. Because the system is set up to decrease access to specialists in those other communities. It's really not addressing the real issue, providing cares in the underserved communities. So again, I think this is about driving policy. Again, this is kind of first world solutions. Not that we're a third world community, but first world solutions. And completely ignoring the fact that there needs to be, because of the fact that we have FQ and safety net, is because in those communities, the current business model does not work. It's just that simple. You're not physicians here, the business model does not work. You can't remain here sustainable. Every one of us that does that is making a very big sacrifice, whether it's primary care or whatever. And even great systems like Kaiser, or whether you SUD or whatever, they can only go as far as their business model allows. The minute that they stop making them, they cannot make money, they cannot be sustainable, they cannot do any more good. They have to stop right there. So again, I think part of the issue here, what we're talking about, and as you said, is about really addressing policy, what's best for those communities. rather than going with policy that's actually best for a whole nother segment. Sorry, I'll get off my soapbox.
And by the way, healthcare needs a lot of managers, really good management. So if any of you are interested in health, but you're not sure you want to be a clinician, if you have a strong interest in management, you're going to be worth your weight in gold, let me tell you.
So, can we have one last question? Because I know we're getting to the very end of our panel discussion, and we wanted to kind of summarize a little bit. One last question?
Yeah, Connie, let's go back to the concordance language everyone says, does it really matter? Does it really matter? First of all, it does matter that people go back to
does it really matter that we pay attention to the populations? And I think this is part of that data that shows you, and I think so we can take a little more time with it. You can see the difference between, well, this is the disparities. Do we have the one where we have concordance? Oh yeah. Oh. So yeah, that's the one. Yeah, that's the language concordance, where we actually took and you can see the Spanish-speaking member with concordant MDs. And on every single measure, they scored better. And these are a lot of patients, so the small percentages means a lot. And Connie, you should probably talk more about that. But
I looked at the numbers and I figured, I mean, I also think that this data is probably not completely
bigger than that.
Because I don't think we're really taking into account other issues, but I do think that this is, in terms of policy, pushing policy in our state, if we, as an organization could support, advocate for data, more disparity data that really talks to the point that in terms of outcomes and actual care for our quality care for our populations, that it is very important to have a physician that you can relate to, and not just for outcomes, but in other realms as well, satisfaction and whatnot. If we can really look at the data very closely, I don't think there's probably as much published as there should be, because people probably are not, as interested in that perhaps as another thing. That we can really probably push from a legislative basis, sort of, that the healthcare workforce needs to change for the, health of our state. So, yeah, the numbers are 10,000 to 20,000 in terms of the diabetes care, and with blood pressure care, the same, and colorectal cancer is on the order of, over 25,000, 30,000 members that are getting better care because of their concordance. But I think you could show this in so many other ways, and I think if we had, if we had more data for the legislators to then use and take and really build the case for our state, it would help us a lot.
Yeah, thank you. I think, on a daily basis we hear from patients who, and they're the driving force, because they're the customers, and they're the ones who, when you talk to people, and there's the first tenet of medicine, first to know wrong, second tenet of medicine is that listen to your patient, she's telling you the diagnosis, but that goes even further. It's not just the diagnosis, but it's really the partnership with patients now, and the ability to really carry out the sort of the plan of treatment, so to speak. And so it's really, we can look toward data, but it's almost on a daily basis. And some of us who have been working on this for years understand that, it really is not just, we can work to try to get the data of why concordance is so critically important, especially around chronic care, and about the ability to help people manage these conditions that they live for. One interesting bit of data, because I love diabetes, and when you look at how many times we asked people to see their practitioner, it's 4 times a year if it was considered to be
high quality care. And when you looked, unfortunately, it was 15 minutes, so it translates to what? 1 hour of interface, face-to-face with your doctor, and all the rest of the hours that you live with diabetes. And so really to understand that it really is about that relationship, about that understanding, you know, what these people, what we as patients go through on a daily basis, can actually work a lot better when you have this concordance, not just with language, but with culture and with the ability to understand the patients, so that the people, so that you can develop that relationship that can address, you know, those conditions like diabetes or like cancer, like COPD. So it's really very critically important that we translate this data into what we believe is really, we need more of us out there to take care of more Latino patients. And that's not to say that we because this organization is not just focused on bringing more Latino physicians, but really addressing the issue of Latino patients and addressing those individuals who want to take this on and understand the concerns and the issues, that we can be their mentors who don't happen to be Latino but deal with Latino patients. So, and it's really about, you know, those other communities, like, you know, the African American communities, you know, the Vietnamese communities, all those communities that are underserved, that we can, not only can we learn and teach, but we can work with each other to collaborate. So I think that's a really critical piece. I wanted to thank the panel because our time is up. It's a great discussion. Like all the other discussions that we had today, I mean, we have to cut them short. But again, this is the beginning of many conversations. We are very actively interested in working, again, with CPHC, the Latino Coalition for the Healthy California. You know, unfortunately, right now, when you look at how many statewide organizations are focused, or community-based organizations are focused just on Latino health as the exclusive thing they do, well, unfortunately, there's only a Latino Coalition on a statewide level in LPOC right now, and which is kind of a sad indictment when you look at these numbers of we have more than just the issue of health, you know, the health manpower to talk about. So we want to continue those discussions and say we want to be the spoke in the wheel of that progress for Latino health. We are planning to create more symposiums like this, both here and in Northern California, and as we mentioned, one of the really important ones is about research in the Latino community. And other key pieces where we brought up, which is a critical discussion, is about the transition of the new payment systems and the new value-based purchasing. And how is that going to impact, and how can we take the opportunity to look at the transition of the healthcare system that, I think as Hector mentioned, as CMS goes, so will the rest of the healthcare system go eventually. And how can we be ahead of it out there, while at the same time addressing the issues of Latino health and Latino professional development. Because remember, we said early on, it's not just about Latino physicians. We call ourselves Latino Physicians of California because that's the most obvious disparity is around Latino physicians, but we really focus on just health professionals in general and really addressing, you know, all of those issues that our comrade health professionals are needing to address that are similar to the things that we're doing with Latino Physicians of California. I want to thank you all because I think, again, this is not just about us presenting out here, but it's really about the interaction that we've had with all of you and with, you know, the feedback that you've given, because this is exactly what we want and what we need. We'll be publishing these symposiums, there's proceedings of the symposium, and then looking forward to the next symposiums in the future, and hope that you can continue to be with us. One last thing.
I just wanted to thank New York Life for providing us with such a wonderful facility and all of the work that they have done. I also want to thank Roberto Gonzalez. He has worked with me. He hopefully will soon be a medical student. And our Director of Marketing and Community Development. This is Carlo Matricardi. It has been hours and hours, and in the beginning we introduced Martin Petoyan, and we also introduced Jorge Urizar, and the two gentlemen back there made this day possible. o'clock at night and all kinds of stuff. They really wanted to make you feel welcome. And so I want to make sure. And I want to really thank the members of the board of the Latino Physicians of California. And Roberto has a little comment with you.
All right, well, thank you so much for the applause. I really appreciate it. And I want to say thank you for coming out today. This means a lot, not only for the Latino patients and the current Latino physicians, but the aspiring Latino physicians and healthcare professionals that I see around the room and are personal friends of mine, and not only personal friends of mine, but also leaders in different organizations. So thank you for that. Just a few housekeeping information. So if you request a CMECU, I kindly ask for you to sign out in that same sheet that you signed in. There was a couple questions about where am I going to receive the test that I need to fill out. We'll be sending that via email. So it'll be a SurveyMonkey, and we'll ask for you to have it in within 7 days. And I'll send all the information out via email. Cool? And that's parking? So parking will not be validated, sorry.
Okay, could you help me thank Leah once again?
Have a safe trip home.
Yeah, thank you.